Hi, this is Colleen Parsons with your Ear Assessment Lecture, Part 1. We want to review your anatomy and physiology, which we're going to pay a little bit of attention to here. Something that I want to tell you, don't forget that you won't be doing the comprehension questions. This will be an ISBAR. So looking at the outer ear, we want to remember that this is the tragus. So that's the part right here where you close off the ear in order to hear. It's better to close your ear with a tragus than to put your finger in your ear that way. We've got the lobe of the ear, and this area here is the pinna, where you need to pull up or down depending on what's going on in the age of your patient. Here's the tympanic membrane. And you can see the three parts of the ear, the outer ear, which is as far as you can see with your naked eye looking into the ear. You have the middle ear, which is where the vibration of sound occurs. And then you have the inner ear here, which is where the tympanic membrane is. Hearing is in three levels. We've got auditory system, amplitude, which is how loud something is, and frequency, which is the pitch. So one of the reasons we use the tuning fork is so that you can have an idea of what conduction is, and that you can actually hear something because hearing is really vibration. And you can hear something without hearing a tone to it. It's very interesting and something that's important for you to know. So people who have a cochlear implant are actually hearing vibration and not a sound per se. So here's hearing loss, can be conductive hearing loss, which involves an actual mechanical dysfunction of the external or middle ear. So something is wrong, there's a foreign body, there's a buildup of wax, there might be something else going on in the inner ear or the outer ear or middle ear. Sensorineural neural is a hearing loss that occurs with cranial nerve 8, remembering that you need to know your Roman numerals, and it doesn't matter how loud somebody talks, you may still not be able to hear them. You may not be able to understand the words that they're saying. It's a gradual nerve degeneration that occurs with aging, and it can also happen with some ototoxic drugs. Aspirin's a good example. Too much aspirin can cause tinnitus and affect people's hearing, even if it's just in a short-term dosage. But quite a few medications will actually cause tinnitus. Mixed hearing loss is a combination of both of those. Equilibrium is often determined by hearing or the function of the ears more than actually the hearing of what's going on. Our ears play a more important role than we probably give them credit. Let's see, developmental competence in infants and children. The biggest thing to know here is that while hearing development starts about in the 5th week of gestation, rubella is a big deal. And if a mother is infected with the rubella virus or German measles, that can damage the development of the ear, not the external ear, but the inside of the ear and the organs that cause hearing. And that can either cause hearing loss or total deafness in children. Otosclerosis is a conductive hearing loss which happens in adults between 20 and 40 years old. It's a gradual hardening that causes the footplate of the stapes to become fixed in an oval window. Impending transmission of sound. So the vibration can't happen because it's stuck, it's gotten hard. No amount of oil or wax can fix it. In aging people, the cilia, or the hair that is lining the ear canal, becomes coarse and stiff, and it doesn't move in a way that allows sound to conduct. Also, especially in men more than women, the waxy buildup in there is drier, and it gets really hard and gets impacted in there. And the only way that is very common to happen, and the only way that we can clear that up and help people hear better, is to get that waxy buildup out. And sometimes it comes out in pretty big clumps. Presbycusis is a type of hearing loss that occurs with aging, even in people living in a quiet environment. The onset is usually about 60. You first notice high frequency tone loss. One of the things that's happening to me personally is that I'm not really noticing a high frequency tone loss, although it might be there. What I've noticed is, and been tested for it, is there's a frequency that my husband talks at that I can't hear. So I can watch his lips moving, and I can't really hear everything he's saying. And it's not all the time, it's just when he's really tired, I can't hear that place. Culture and genetics, otitis media, and which is a middle ear infection. That is, there's been a lot of controversy around that. So, and what I mean about controversy is whether or not we actually treat it. And it comes more in a bacterial load. If that bacterial load is high, and it's happening more often in European Americans or European New Zealanders. There are two types of waxy substances, earwax, and that one is dry, flaky. It comes in usually a pretty big, thin mask. It looks like a layer. And then there is wet, which is the honey brown to dark brown waxy stuff, and that's usually, that's the most common. That is genetic as well. So when we start to ask our subjective questions, any earache or other pain in ears, same thing. And then when you get to the palpation, and you might be doing both at the same time, you're going to be palpating, and you're going to be asking if there's any pain and tenderness as you're inspecting the ears. You want your patients to describe the pain as best as they can, and if they say yes, they do have some pain, don't forget to get that level from 0 to 10. Infections. Does your patient have a history of ear infections as a child or as an adult? How frequent are they, or were they? How were they treated? We know that if sinus infections or ear infections are frequently treated with antibiotics, that patient is going to have more problems with antibiotics as an adult. So we've decreased the amount of prescriptions written for these things. Now that makes it hard for the prescribers because patients go in and they demand something. They just want you to treat it, and they demand that you treat it. So you're also going to be asking your patient if they have any discharge from their ears. What does the discharge look like? Is there any pain with this discharge? Have they ever had any trouble hearing, and all of the questions that go along with trying to determine what type of difficulty they're having with their hearing. Have they ever had, or do they presently have, a hearing aid? Is there anything else that helps? Coping strategies. So for me, with my tinnitus, the only thing that really helps is if there's another noise going on that's a little bit louder than the tinnitus, and then it doesn't drive me crazy. But sometimes I like the quiet. Sometimes the tinnitus is so distracting that the quiet is uncomfortable. So as you are asking your subjective questions and getting a feel for what's going on with your patient, you can watch them, and are they frowning or straining, or do they keep, like I would say, I'm sorry, I can't hear you. Can you say that again? People saying what? How they are speaking. So if their speech is sounding garbled, or if their vowel sounds are distorted in some way, they might have a long-term hearing loss. If they are talking inappropriately loud, they might be thinking that you can't hear them, and you can hear them just fine. And that's the end of part 1.